bit later when they arrive. So, hi, I'm Laura Redwine. I am the research director at the Osher Center for Integrative Health. I'd like to welcome everybody to the University of Miami Osher Center for Integrative Health Wilson Foundation Grand Rounds and Speaker Series. And today I would like to introduce to you, it's my pleasure to introduce you to Dr. Annette Fornos. Dr. Fornos is a board-certified internist in Miami, Florida. She completed her undergraduate career at the University of Miami, earning a Bachelor of Science summa cum laude in biology and a minor in chemistry. She attended medical school at the University of Miami School of Medicine, did a residency in internal medicine at Jackson Memorial Hospital. Dr. Fornos has served as an assistant professor of internal medicine at the University of Miami Miller School of Medicine and as faculty at the Institute for Neuroimmune Medicine at Nova Southwestern University College of Osteopathic Medicine. She is board certified in functional medicine by the American Academy of Anti-Aging Medicine and chronic inflammatory response syndrome by the Institute for Functional Medicine. Dr. Fornos is a fellow in anti-aging and metabolic medicine by the American Academy of Anti-Aging Medicine and George Washington University. She's completed numerous postgraduate functional medicine courses, including in bioidentical hormone replacement therapy, IV and chelation therapy, and in peptide therapy. And as a little side note, Dr. Fornos is a certified Kundalini yoga teacher by the Kundalini Research Institute. And so I would love to introduce you to Dr. Fornos. Thank you so much for being here.
Thank you, Laura. Thank you, everybody, for being here today. So I'm Annette Fornos, for those who don't know me. This presentation is in one of my favorite topics, bioidentical hormonal replacement therapy, specifically for postmenopausal women. Okay, I'm trying to switch slides. Yeah, there we go. I have nothing to disclose except that I do not consider myself an expert in any field, but an expert student of multiple fields in functional medicine. The objective of today's presentation are to understand the indications and applications of postmenopausal hormonal replacement therapy for females, to explain the benefits of bioidentical hormonal replacement therapy versus non-bioidentical, to review the metabolism of hormones and why it's important to monitor therapy, and a brief review of the literature. Time permitting, I will also go into some examples of how to prescribe compounded bioidentical hormonal replacement therapy for women. And unfortunately, due to time, I will not be able to cover men or male hormonal replacement therapy today. Okay, so this slide just illustrates the prevalence of the main reproductive hormones in females, highest during the reproductive years. And here a little bit of a refresher of the female reproductive cycle, starting at the hypothalamus with the release of gonadotropin releasing hormone. Move something away from my screen. So gonadotropin releasing hormone, pulsatile release going to the anterior pituitary, where it triggers the release of FSH and LH. FSH, as we all remember, starts by stimulating the follicles to grow. As follicles grow, they begin producing estrogen. Estrogen promotes endometrial thickening in preparation for implantation, should there be fertilization. It also exerts a positive feedback on LH and a negative feedback on FSH. Ovulation takes place later due to an LH surge, when the dominant follicle releases an egg and becomes the corpus luteum. The corpus luteum begins secreting progesterone, which further prepares the endometrium for implantation, inhibiting FSH and LH further release. And if no fertilization takes place, then it degenerates, and it's this progesterone withdrawal that leads to menses. So I have to remove something from my screen. Here we go. And so I'm going to skip the male reproductive cycle. removing something, sorry about that. And this slide just illustrates on the left-hand side the normal functions of estrogen during the reproductive years, illustrating that they're not just limited to the sex organs. And on the right-hand side is what happens when that's out of balance, how excess estrogen in this case can lead to proliferation. Here is one of my favorites. I know many people hate this diagram. I just use it as a reminder to help understand what's going on. This is happening in the adrenal glands, which also produce sex hormones. And if you remember, the adrenals have two parts, the cortex and medulla, and the cortex is further divided into three different parts. In the outermost layer, which is the adrenal cortex, zona glomerulosa, we have the production of aldosterone. What's important here is that they all come from the same precursor, cholesterol and pregnenolone. As we move further into the gland, into the zona fasciculara, we have the production of cortisol. And as we move along into the zona reticularis, or the innermost layer, again, from the same precursors, cholesterol and pregnenolone, this time going towards DHEA, we get the production of androgens, including ultimately testosterone, and from there, estrogen. And it's just a quick refresher. If we take the part that just pertains to sex hormone synthesis, we can see this illustrated in this diagram a little bit better, in which we have from pregnenolone to progesterone and also to DHEA, both leading to androstenedione, and then from there, testosterone and estrogens. The next slide illustrates the main types of estrogen receptors, the main ones being alpha and beta. Alpha receptor, it's different from the beta receptor in that it's proliferative, excitatory, pro-inflammatory. It increases processes such as glycolysis and is angiogenic, meaning more blood formation of blood vessels. Whereas the beta receptor tends to downregulate the alpha receptor, and it's anti-proliferative, anti-inflammatory. It has an active function in estrogen detoxification. It increases brain-derived growth factors, so for positive effect in the brain, and it's also anti-anxiety or anxiolytic. And so this is important to understand because the different organs have different type of receptor predominance. In the brain, for instance, we have the predominance of the beta receptor, whereas in ovaries, endometrium, and breast, we have the predominance of alpha. In case of the breast, the predominance is 5 to 10 times alpha receptors to that of beta. And so that becomes very important later on as we advance in the presentation. The colon has a predominance of beta as well as fat tissue. And when it comes to bone tissue, alpha predominates, but beta has a regulatory effect. And in the placenta, we have also the predominance of beta receptors. And this table illustrates the different types of estrogen, estrone or E1, estradiol or E2, and estriol or E3. So estrone predominates in the postmenopausal years, and it has a prevalence or predominance for alpha receptors in a 5-to-1 ratio. So it's more pro-inflammatory, it's more angiogenic, and it's more proliferative. Estradiol is the one that predominates during the reproductive years, and it has a 50-50 affinity for alpha and beta receptors. And estriol predominates during pregnancy, and it has a preference for the beta receptor, which makes sense. Here, I'm just going to list some of the benefits of estrogen, not only limited to reproduction, but also metabolic rate, supporting insulin sensitivity, body temperature, maintaining muscle. It has favorable effects on cholesterol. It also decreases the risk of coronary artery disease by contributing to decreased Lp(a), homocysteine, and arterial plaque. It helps to dilate small arteries. Therefore, it has also a regulatory effect in blood pressure and organ perfusion. And this is by the influence on nitric oxide secretion by the endothelial layer. It helps to maintain bone. It is a natural antioxidant. In the brain, it has multiple functions, especially at that beta receptor. It supports NMDA receptors, improving memory. being brain-derived growth factor, supporting nerve conduction and neuronal connection. It increases glucose and oxygen delivery to the neurons. It supports acetylcholine communication among neurons and helps to decrease beta amyloid plaques as well. It supports the blood-brain barrier. It also turns on the progesterone receptor, which is important for self-regulation, and it has an important effect against cataracts and macular degeneration. And therefore, it makes sense that excess of estrogen will lead to trouble because we saw the effects of alpha receptor activation, such as endometrial proliferation, endometriosis, uterine fibroid cycle, heavy cycles, PCOS, anything that's estrogen dominant. Weight gain, it affects the conversion of T4 to T3 and increases thyroid hormone binding globulin, therefore having a little bit of an effect on hypothyroidism. It also leads to fatigue, mood swings, irritability, issues with sleep, breast tenderness and swelling, etc. Important to notice that this is about balance. So excess and deficiency are both not optimal. In the case of estrogen per se, estrogen excess and deficiency can both lead to an increased risk for autoimmune conditions. And deficiencies, therefore, will lose the protection, the cardiovascular protection, so we have an increased risk for cardiovascular disease, as well as osteoporosis, issues with memory and learning as well. Some of the benefits of progesterone, it helps to balance estrogen. Remember, estrogen turns on the progesterone receptor. Progesterone also protects the endometrium against proliferation. Progesterone supports sleep. It has a natural calming effect. It has beneficial effects in cholesterol, fat metabolism, supporting of scalp hair, metabolic rate. It's a natural diuretic. It promotes T helper 2 type cell immunity. It's neuroprotective, among others. And then again, it's about balance. Excess, unopposed progesterone versus deficiency are both detrimental. With excess, we lose the protection of, the estrogen in the cardiovascular system and cholesterol patterns. It affects libido, insulin resistance or sensitivity. It can also contribute to bloating, gas, gallstones, etc. And deficiency, anxiety, irritability, insomnia, pain, inflammation. We lose the bone protection as well. And if during pregnancy, it may lead to first trimester miscarriages because progesterone is produced by the corpus luteum during the first trimester of pregnancy. Testosterone is beneficial in females as well, supporting sexual interest, emotional well-being, muscle mass, memory, decreases excess body fat, it maintains bone as well, and then it increases norepinephrine transmission, among others. And DHEA here, which remember is a precursor to sex hormones, it helps to balance cholesterol and fatty deposits. It helps with prevention of blood clots. It also supports bone formation, promotes weight loss, supports brain function. I like the effect that it has on cortisol because it is a natural buffer for cortisol, especially during times of chronic ongoing stress. It also supports the immune system, maintains tissue repair, and it also has beneficial functions in allergic reaction, among others. And pregnenolone, remember, is an even earlier precursor to cholesterol, to cortisol, to sex hormones. It regulates the balance between excitation and inhibition. It increases the resilience to stress. It supports nerve transmission, modulates pain, supports GABA, repairs nerve damage, supports mood, sleep. It also modulates the NMDA receptor, contributing to memory and awareness and learning. It's anti-inflammatory as well. I don't have much time, unfortunately, to go in detail about cortisol. That would be a whole different lecture. But I just wanted to pinpoint that it's the only hormone that naturally increases with age. And not only does it have an effect in stress, but it also has an effect in regulation of blood sugar, immunity, sleep, etc. And then just a couple pearls here. Patients with PTSD initially can have a high cortisol, 24 salivary cortisol when measured, in a 24-hour period, but eventually with ongoing hypercortisolemia, you can basically undergo fatigue and lead to hypocortisolemia. In the hyper states, unopposed high chronic cortisol in the brain, specifically in the hippocampus, will cause detrimental effects when it comes to emotional regulation, learning, and memory. Initially, those effects could be reversible in the early stages when there is inflammation, but later on when there is atrophy, unfortunately, many times those may be irreversible. And then it can cross the placental barrier as well. Melatonin, we shouldn't forget about it. It's not just for sleep. It has a very important role as an anti-inflammatory and immune modulator and natural antioxidant as well. So on the second part of my lecture, I wanted to move on into what's important when we're considering hormonal balance, whether it's replacement or monitoring in the premenopausal state. As with any hormones, we need to think what's the input, the metabolism, and the output of that hormone. So the input refers to the production and any feedback that can affect that production, whether it's positive or negative, and the ability of the adrenal gland, in this case, or sex organs to produce sex hormones. Metabolism refers to how are those hormones transported to the sites of what they're needed, how they are utilized, which has a lot to do also with receptor sensitivity. And then ultimately, once they exert their function, we need to look at how do we detoxify or get rid of excess hormonal metabolites. And this would be through mainly detoxification processes, phase 1 and phase 2 in the liver, and then ultimately elimination. So estrogen elimination or excretion at the right-hand side is, in my opinion, in reverse order. I think this is the first phase of elimination or detoxification, because if our kidneys and colon or GI tract are not working optimally, let's say we have severe constipation, we will not be able to excrete excess hormone metabolites. And so in the liver, we have phase 1 with detoxification, which is dictated by the cytochrome P450. And the major enzymes involved in the metabolism of estrogen are CYP1A, 1A1, 1B1, and CYP34A. Then after they undergo phase 1, they become temporary intermediate oxidate free radicals, sorry, and then eventually they need to get neutralized by phase 2 in order to go towards excretion. So what's involved during phase 1? We have the cytochrome P450, mainly the 1A1, 1A2, 1B1, and 34A, followed by phase 2, which include the processes of methylation, glucuronidation, and glutathione conjugation, these being the main 3 that have to do with hormonal detoxification. Then that hormone, in the case, it could go to the kidneys for excretion, or in the case of the gastrointestinal tract, it's bound to bile and it goes to the colon where it should be excreted. Now, what happens in the colon is at the very top of this figure, we see an intact colon with an intact membrane, and that's the way it should look. But in the case or in the event of ongoing inflammation, whether it's infection, toxins, chronic cortisol from chronic stress, you name it, we can develop intestinal hyperpermeability with disruption of tight junctions. Not only that, but we can also develop dysbiosis. Excess dysbiosis of gram-negative bacteria lead to the production of beta-glucuronidase. This is an enzyme that deconjugates the bond between bile and whichever toxin was already bound and destined for excretion. When this happens, hormonal metabolites get reabsorbed during the enterohepatic circulation, which is why with my patients, I always start addressing what's going on in the GI tract. So again, this illustrates what I've mentioned, elimination. We talked about phase one, producing those intermediary free radicals, which are 2H1, 2OH, 4OH, and 16OH. OH stands for hydroxy. The 2-hydroxy, which is down the 1A1 pathway, is the preferred intermediary. However, it is still a free radical and must be neutralized. It is mainly neutralized by methylation, which is a phase two. And that is the main phase two, by the way, pathway for hormonal detoxification. Then the 4OH goes down the 1B1 pathway, and that one leads to the production of quinones. If not neutralized, it will directly damage DNA and lead to mutation, and that would be a procarcinogenic state. Or it could also be neutralized through methylation. And then finally, the 3A4 pathway goes to 16OH. 16OH is pro-inflammatory when in excess, and the ideal ratio of 2OH to 16OH should be 2 or higher. Unfortunately, in estrogen dominant state, whether it is premenopausal or postmenopausal from just supplementation, many times, especially in the premenopausal conditions that lead to estrogen dominance, that ratio is not just reversed, but it's much higher in the 16 to 2OH ratio relationship. And so why is this important? Because in functional medicine, we can intervene. And by intervening, we can favor those preferred pathways, in this case, the A1A and then methylation. And what are natural things that may favor those favorable pathways? 1A1, resveratrol. These are just a few, not all of them, of course. Resveratrol, highly antioxidant, ellagic acid from berries, ECGC from green tea, kava, DHEA, indole-3-carbinol, and DIM that are derivatives from cruciferous vegetables. You may wonder here, as you can see, the same ones that may support 1A1 may also support 1B1, some of them down here. But this is a dose-dependent relationship. So at higher doses, they have a preference for the 1A1 and the 1A2 beneficial pathways. What else is important? What factors can interfere with natural estrogen metabolism? Obesity is one of those things that reverses the 2OH to 16OH ratio. Furthermore, fat cells have aromatase, so they can increase the aromatization or conversion of testosterone to estrogen. Think of your male patients that are on testosterone replacement therapy and are obese and may have increased aromatase activity and be in a hyperestrogenic state. That would be for when we talk about males. Estrogen is also stored in fat cells. It's a fat soluble. It's a hormone, so hormones are fat soluble. Obesity contributes to low sex hormone binding globulin. Xenoestrogens are potent estrogens that have higher estrogenic activity than natural estrogens. And xenoestrogens can be found in pharmaceutical industry, plastic, cosmetic industries, pesticides. And they have a preference for the pro-inflammatory pathways 4OH and 16OH respectively. What also is important is what else is competing for those enzymes. For instance, alcohol competes with a cytochrome P450. It has a preference for the YP2E1, the different pathway, but in excess, it will be partially metabolized down through the 1A2 and the 3,4A. So partially blocking those enzymes that metabolize the 2OH pathway and the 16OH pathway. And then think of indiscriminate or multiple use of antibiotics, both personal but also in the food industry, and how those may alter the microbiome and lead to dysbiosis of gram-negative bacteria, lipopolysaccharide, and beta-glucuronidase excess. So what are natural interventions to raise the 2OH pathway? Cruciferous vegetables, physical exercise, flaxseed or fiber, indole-3-carbinol, DIM, sulforaphane, all derivatives from broccoli, omega-3s. Then we also should support phase 2 methylation pathways, in this case through B vitamins, methylated folate B12, trimethylglycine, and obviously weight loss and protein, lean protein. Phase 2 pathways, as I mentioned before, these are the 6 main phase 2 detoxification pathways. The top 3 are the main ones for hormonal detoxification, primarily just because it's more commonly used, it will be methylation. This is important because we can't measure. So this slide shows one of the tests that we can do to address hormonal or any toxin detoxification, in this case, through the methylation pathway. The purpose is not to understand the test, but just to illustrate that tests are available. And the bottom half, we have the phenotype, what that pathway looks like, any deficits, any a cofactor deficiency or any toxins that may interfere with that pathway. And then on the very top, we have the genomics associated with those enzymes. So now going into menopause, what are some of the symptoms of menopause? Well, we're all familiar with these: lighter bleeding, but in the beginning, we can experience heavier bleeding. And it's because the first stage of hormonal imbalance during menopause is actually has to do with low progesterone with respect to estrogen. So it's a temporary hyperestrogenic state. So we could experience heavier bleeding initially, breast tenderness, menstrual irregularities, differences in cycle and length and duration. Also, as estrogen levels begin to decline, and it's the actual fluctuation of estrogens that set the terrain for vasomotor symptoms, being hot flashes, night sweats. So the fluctuations in estrogen set the terrain, but what triggers the hot flash right now and not 30 minutes ago or an hour from now, it's an acute increase in norepinephrine, epinephrine. So this could be secondary to stress, an acute stressor, a dream even, because it does tend to happen during sleep. So it's a combination of both things. So it's important to also, practice any activity that can help to decrease stress or to increase stress adaptation. With vaginal symptoms or urogenital symptoms, we got dryness, irritation, dyspareunia. You can also experience changes in libido, sleep, rapid weight gain, mood changes, irritability, cognitive changes. Remember the beneficial effects of estrogen in the brain, and also additional genitourinary symptoms such as incontinence frequency, etc. And these two slides I'm going to skip. It's just illustrating what I just mentioned at the different organs and tissues. So a little bit about cardiovascular health and menopause. So with hot flashes or vasomotor symptoms, they have been found to have a high association to cardiovascular disease. By means of endothelial dysfunction, remember nitric oxide, it can also be associated with increased carotid intima thickness. The severity of the hot flashes or the frequency correlate to increased risk for cardiovascular disease, as well as higher systolic blood pressure, and obviously adverse lipid parameters. Furthermore, they're associated with a higher risk for metabolic syndrome. The higher the frequencies of the vasomotor symptoms, the higher the risk. Also, insulin resistance, non-alcoholic fatty liver disease, higher rate of bone turnover, leading to lower mineral density and cardiovascular disease, as previously mentioned. So What is important to know prior to hormonal replacement therapy in postmenopausal women? Remember the production of hormone, then the utilization, and then the excretion. All of those things are important. So we need to know, in addition to that, the levels. And I always begin by checking baseline levels. I'm going to skip this slide. This one just illustrates how we can measure. And this one particularly is measuring 24-hour, 4.24-hour salivary cortisol. Here, back to the serotonergic pathway. I love this, but I use it as a reference. I never, think that we necessarily need to memorize this, but I just wanted to illustrate all the boxes, even if you can possibly not read them. What that it's trying to illustrate is that at each particular step, there is a possible intervention. And that's why it's so important to know what's going on so that we can intervene favorably. So this next slide shows the general lab tests that we can do to measure hormone. And these are the main types. Serum can measure circulating free hormone as well as bound hormone. Saliva measures unbound and free active hormone. And urine measures metabolite of hormones. And so again, another illustration of the same thing, saliva, urine, and serum being the most common. What can we test? We can test for fractionated estrogens, progesterone and metabolites, androgens, androgen metabolites, cortisol, DHEA. We can also test for melatonin as well in saliva. So I will summarize this, but briefly, what does serum testing measure? Circulating, bound, and free hormone. What's important about serum and why we should use it and know how to use it is that it contains the most amount of literature. So even within the functional medicine community, there are, practitioners that favor salivary monitoring for transdermal because it most closely correlates to what's available at the tissue in free unbound form. However, there is not enough data or literature out there. So the literature exists mostly for serum testing. And so when we're testing for serum, we have to keep in mind that progesterone is unstable. It gets rapidly converted to their alpha and beta metabolites and is primarily bound to corticosteroid binding globulin. It's very fat soluble. Androgens and estrogens primarily to sex hormone binding globulin, and some sex hormones also bind to albumin. And then again, for cortisol, the gold standard is salivary testing, and also for DHEA, because DHEA is highly, it gets metabolized really fast and converted into the DHEA sulfate form through sulfation. Also for cortisol, we have dry urine metabolite, but I'm not going to dwell on cortisol today for the sake of time. Estrogen, again, how do we measure? I like to obtain a baseline postmenopausal serum level using the main labs known to us, and then using the LCMS methodology. You can use saliva for transdermal, but like I said, there's more data on serum. What you have to know is how to use serum data to titrate or to adjust dosing when it comes to transdermal. And then for dry urine metabolites, it's very important because it measures how those hormones are being metabolized and how we can add. So I guess the dry urine will be the preferred method. However, because of insurance and easy of use, I rely a lot on serum testing. Testosterone serum, it's sufficient, although it's important to also know what the metabolites are doing. And this is an example of the Dutch test. Again, the point is not to understand the test, just to illustrate that it exists and that we use it and that we can intervene. So at the top right corner, we have the metabolites of progesterone, alpha and beta. Alpha, it's more function of in terms of sleep and calming effect, whereas beta is more protective against hyperestrogen or estrogen dominant states. In the middle left, we have the metabolites of androstenedione. And then on the right-hand side, we have the different metabolites of estrone. One down to 2-OH, 4-OH, 16-OH pathways mentioned above, and how those are further neutralized through methylation or glutathione conjugation, or in the case of 16-OH, how it can retroconvert to E3 or estriol. This is another example of an application for Dutch test. It's called cycle mapping. It's used for premenopausal women when they are trying to see any irregularities of their cycles or fertility purposes. And so DHEA had to measure salivary, very accurate, 24-hour 4-point, or DHEAS in serum. And this table summarizes what the preferred methods are for different hormonal types. So I'm going to mention the main three: estrogen, testosterone, progesterone, as we move along, but I just wanted to illustrate that this table can be very useful. And so cortisol, saliva, and dry urine, preferred methods. For transdermal, yes, you can use saliva, but because of what I mentioned before, the data and the ability to utilize what's covered by insurance, I use serum and dry urine. I always do dry urine with hormone replacement therapy after the patient has been on hormones for a little bit. So, if you do it too early, you may find falsely low levels just because there was no hormones to begin with. And then for oral supplementation of progesterone, it's really, so in serum, it's really an underestimate. It's not an accurate level because it gets metabolized fast. So you really is the dry urine metabolites that are preferred. And then what to think about when we have a menopausal female that wants hormonal replacement. And this is a brief review of the literature. The North American Menopause Society in 2022 position statement stated that hormone therapy remains the most effective treatment for vasomotor symptoms and for genital urinary syndromes of menopause. Also has been shown to prevent bone loss and fracture. And for this, personalization is key, with shared decision-making between practitioner, physician, and patient, and periodic reevaluation to determine the individual risk versus benefit. They further state that the benefits of HRT outweigh the risks for most healthy symptomatic women. The key is symptomatic, right? Vasomotor symptoms, who are younger than 60 and within 10 years of menopause. Transdermal routes are preferred, and lower doses of hormone therapy, the lowest effective dose possible, to decrease the risk of stroke and venous thromboembolism. And then women with primary ovarian insufficiency, premature menopause, surgical menopause should start earlier and keep and stay on the hormone replacement therapy at least until the mean age of menopause in the absence of any contraindications. Their statement or their position on bioidentical compounded hormonal, they stated that it presents safety concerns because of lack of government regulation and in potential issues with sterility or manufacturing in general. But as we shall see later on, those have also been evaluated. And then there's no need to discontinue hormone replacement therapy necessarily in women older than 60 to 65, as long as they are experiencing benefits and you're monitoring and it continues to be safe and it's a shared decision-making process. So why are they so skeptical of bioidentical compounding? Because of lack of understanding by the traditional medical system, but also because of lack of regulations. The truth is that bioidentical hormones have been studied along non-human bioidentical for decades, and the compounded hormones contain the same amount of estradiol and bioidentical progesterone as commercially available bioidentical hormones. This is a very old study. Just to illustrate this, use conjugated equine estrogen and progestins, not bioidentical, 10,000 women, and 97% did okay, but they did find issues with BVT, strokes, and breast cancer, among others. What the limitations of the WHI study was that the average age of the study was way after menopause. The average age was 63. They do not use bioidentical. They used equine conjugated estrogen and medroxyprogesterone acetate, and they also did not screen for pre-existing risk factors. So endocrine society guidelines benefits exceed the risks for postmenopausal women, for most postmenopausal women that are symptomatic, younger than 60 or within 10 years of menopause. The evidence does not justify hormonal therapy to prevent heart disease, breast cancer, and dementia, although multiple studies exist that support this. The women that have moderate to increased risk of blood clots, it's a no-brainer. Use transdermal, and if they have a uterus, use progesterone for protection. Treat for the shortest duration, but women with premature ovarian failure and the like should start as soon as possible and keep it until at least the average age of menopause. And they also found that HRT may decrease the risk of diabetes by 14 to 19%. So what are the FDA approved indications for HRT? Is a first-line therapy for the relief of vasomotor symptoms, protection of bone, and then for females with hypogonadism, premature ovarian failure, like I mentioned before, and then low vaginal estrogen therapy. It's a first-line treatment for isolated genitourinary symptoms. There is no general rule to discontinue after 65 in women that have tolerated them well and are doing well, as long as you counsel and document. And in functional medicine, I'll take it a further step, monitor levels. And who shouldn't use it? This women who initiated between 10 and 20 years post-menopause or greater than 60. And this is by the guidelines. And then greater absolute risks of CAD, stroke, DVT, and dementia. With caution, in functional medicine, we can initiate in some of these women, as we shall see later. What the experts do agree on, it's that the benefits outweigh the risk for symptomatic women younger than 60 within 10 years of menopause. So this is a very old study, nurses study, 1991, almost 50,000 participants, again, using conjugated equine and medroxyprogesterone acetate, which are non-bioidentical. And then 1998, the Hertz trial also used conjugated equine estrogen and medroxyprogesterone acetate. So Esther study came out in 2007 that compared oral and transdermal estrogens with different types of progestins. The progestins are not bioidentical. The conclusion was that oral but not transdermal was associated with an increased risk of venous thromboembolism. Esther study used a follow-up to Esther study 2007 meta-analysis. The odds ratio of the first venous thromboembolism with oral estradiol was 2.5 versus transdermal 1.2. The conclusion, again, oral increases the risk, but there was no significant increased risk with transdermal estradiol. So timing hypothesis, let me see, I'm going to try if I need to go over this slide, and I think I have already covered it. For the sake of time, I'm going to move along. So the follow-up to the WHI statement, JAMA of 2010, estrogen plus progestin was associated with greater breast cancer incidence. Progestin, this is the important word, progestin, which is not bioidentical, and the concerns are most commonly no positive. Breast cancer mortality was also higher when combined estrogen and progestin. This is a study in 2003, PPS study that used conjugated equine estrogen again with medroxyprogesterone acetate, and it also used conjugated equine estrogen with bioidentical micronized oral progesterone. So the conclusion was that the combination of non-bioidentical estrogen and progesterone, but no estrogen alone, was associated with an increased risk of mammogramic density. but then they concluded that the actual risk still remained uncertain and that more research was necessary. EPIC Fournier study, 2005, 55,000 women, compare estrogen alone, estrogen plus progestin, and estrogen plus micronized progesterone, which is bioidentical. And so they concluded that the association between HRT and breast cancer varies, and this is important, according to the type of progestin used. There was no or little increase with estrogen alone or combined with micronized progesterone. And this confirms the previous finding that an increase in invasive breast cancer with combined synthetic progestin compared to no HRT. So again, follow-up study, 80,000 women. They found that in this group that to transdermal estrogen and micronized progesterone bioidentical, there was no increased risk for breast cancer compared to those women who had never used hormones. So the issues with oral estradiol, why it may be an issue, it's because it's pro-inflammatory, increases CRP, cardiovascular risk, increases the risk for non-alcoholic fatty liver disease, increases sex hormone binding globulin, and increases the risk for venous thromboembolism. It tends to favor the alpha proliferative receptor. So bioidentical progesterone, no increased risk for breast cancer. Progesterone causes cell death, meaning apoptosis, whereas progestins, the non-bioidentical, are proliferative and anti-apoptosis or apoptotic. There was no increased risk in blood clots and coronary artery smooth muscle with bioidentical progesterone oral and no elevation in CRP. So again, progesterone protective and progestin increases the risk for inflammatory and so forth. And so what about that statement on compounding? So there was a study conducted by the American College of Obstetrics and Gynecologists evaluating 15 compounding pharmacies, and they found that there were throughout the United States that they did not raise any safety concerns when assessing for potency, sterility, and impurities. So a little bit, I'm going to be briefly to leave time for questions, but what do we do now? We have this patient who wants hormonal replacement therapy. There are commercially available bioidentical hormones, patches, gels, there's oral micronized progesterone or prometrium, vaginal DHEA, and then there's oral as well. I tend not to favor oral for the reasons already mentioned. So when possible, use what's available commercially. Why? Because it is bioidentical and it is covered by insurance and it follows the guidelines. But what is important if you are going to compound? When can you compound? When it's approved to compound, when the patient has an allergy or a sensitivity to the base used in the patch, or when using gels that are peanut oil based and the patient has an allergy to peanuts. So that's already justifiable, or when the patient's ideal dose differs from what's commercially available by at least 10%. So I do have patients that prefer compounding for these reasons. How do we compound? What's available for compounding? You can compound estrogen, you can compound progesterone, you can compound testosterone, DHEA, you name it. So when compounding estrogen in a postmenopausal woman, remember that that beneficial effect of E3, that estriol, that is anti-proliferative, but it's also protective. So if you write a prescription and you just write by est, that is automatically understood as combination E3, E2. If you don't specify the percentage or the ratio, it is assumed that it's an 80-20 ratio. So you can start a postmenopausal woman at biased 80-20. Lowest possible dose, 0.25 milligrams per gram of cream. And then for clicks are equivalent to 0.25 times 80% of that will be estriol. 0.25 times 20% of that will be what that patient's getting of estradiol. If the patient underwent abrupt menopause, surgical menopause, early menopause, then you may want to increase that ratio of E3 to E2 to a 50-50 or even a 30 E3 to 70 E2. This is personalized, and this is the beauty of it because it allows us to really personalize to patients' need and benefits while we monitor. You can use a day off, a holiday, but most patients don't like this because this may lead to spotting. And then if the uterus is present, you must use progesterone. What protects the endometrium? Oral micronized progesterone or vaginal progesterone. But if you want the added benefit in the brain, sleep, and for anxiety, I prefer progesterone that's in oral form. If the uterus is absent, the guidelines do not call for the use of progesterone, but I still use it if my patient suffers from anxiety or sleep issues. And then you can dose vaginal, you can compound vaginal progesterone for those genitourinary symptoms. You can use E3, which is the most benign. You can use it daily for the first 2 weeks at bedtime. And then for the next 2 weeks bi-weekly, and then you use it PRN or as needed. Use a mucoadhesive base to enhance absorption locally. And of course, if the patient has a vaginal atrophy, the dose may be slightly higher. Compounding progesterone postmenopause. Again, if the patient doesn't tolerate oral commercially available or needs a dose that's within 10% of what's available, you can use progesterone compounded. E4M stands for sustained release in the compounding world. So you can compound anywhere from 75 milligrams to 150 milligrams or higher orally at that time. Again, if you give a day off, the patient may spot in between. Again, same thing, you can use vaginal compounded vaginal progesterone as well. And testosterone can be compounded. I prefer to compound separately than estrogen in the initial stages to be able to achieve steady state before I combine it with estrogen. And remember, testosterone conversion to the HT and to estrogen through aromatization. And then this is an example of the combination of biest, E3, E2, and testosterone with oral micronized oral progesterone compounded extended release. And as I said, we don't have time for males, sorry, but this is very important. My compounding pharmacists are my right hand. I call them, I reach out, and I have established a relationship with my favorite. They can be very useful. These are my references, and I'm gonna pause here to take any questions.
Wonderful. So we have 5 minutes for questions. If you can stay for a few minutes longer. Oh no, you have a patient at one. So
yeah, but I'm good. Yeah.
Oh yeah. So we have a couple minutes after that. So the first question is from Dr. Schwartz. Which vitamin supplements are most important for patients with menopause who are not able to afford all the needed supplements indicated for their symptoms?
So I remember, thank you, Dr. Schwartz. I would start with phase 3, elimination, fiber, hydration, healthy bowel movements, healthy microbiome. Then I would support phase 2, which is the most common detoxification pathway, being methylation. So B vitamins, methylated B vitamins are would be my go-to. Not everybody needs them, but a patient that can test, it's safe to just try and see how they do. And then for phase 1, we can use green, if they're unable to afford any nutraceuticals, green tea, cruciferous vegetables are very useful, flax as well.
Thank you.
Okay, so here's a question. Is it advisable for a 56-year-old, and I know you don't give specific advice to individuals, but just as a general, is it advisable for a 56-year-old postmenopausal patient who's had a hysterectomy to take solely estrogen? One of the physicians prescribed estrogen but not progesterone. Is this dangerous?
Well, first of all, does the patient need to be on HRT? Remember, they need to have those symptoms. And yes, if they need to be on hormonal replacement therapy and they don't have a uterus, you do not have to protect the uterus. So you don't need to give progesterone. Those are the guidelines. But remember, progesterone also have other benefits like sleep, calming, etc. So learning, memory, bone. So if the patient is concerned with a shared decision making, you can give oral micronized progesterone, but that's a personal choice. You don't have to for uterine protection.
Okay, so here's one that's asking about consultations and insurance. And I was thinking that maybe we should get email address from those individuals and you can contact them directly. Does that sound like a good
Okay,
way to
I
deal
just
with
want to
it?
say that unfortunately, these in-depth, except for the serum testing to our main labs, this in-depth metabolite tests are not covered by insurance.
Okay, great. So so if you have any questions about insurance or consultations, I guess I'll put your email in the chat. So let's see. Okay, so here's a question. What do you think what is your opinion about pellets?
For women, I suppose, and
So,
I suppose you're talking about testosterone. So there's in essence nothing wrong with pellets, testosterone for females. The problem is when and how to use them. I do not use them and I am not an expert, but I believe in first reaching the steady state with a form of hormone replacement that you can easily change, that you can easily stop, or that you can easily titrate. And therefore, that's not a pellet, right? Once it's in, and you have to wait until it wears off. So, but once you reach that steady state, if the patient wants to, for ease of, you don't have to use it every day and so forth, you can convert. You can convert what's, available topically, let's say, to a pellet form. And then you continue to monitor the same way. But in essence, it's safe as long as it's done properly.
great, great. So yeah, estrogen and testosterone pellets. I guess they were specifically.
Same thing, right?
Oh,
Because we
same
want to
thing.
know what's your ideal state. You've been on hormones for a while, transdermal estrogen replacement, and your levels look good, your symptoms are controlled. We try to use the smallest or the lowest effective dose. So start with transdermal.
And then what about for bone support for older women and estradiol?
Yes. So there's this
Ultra
literature.
low.
Yeah,
Mhm.
the literature supports bone protection with estradiol, transdermal patch. Okay, there's not enough data on gels. It's not that it doesn't work. I believe it does, but the data, mostly the studies refer to the use of the patch, commercially available estradiol patches for bone protection and prevention of and maintenance, or at least slowing the progression of, or limiting the progression of osteoporosis.
Okay, so Dr. Fornos, can I get your email address really quickly because I've been trying to paste it and it's not working, but
Oh,
it's
okay.
so sorry.
Yes. No, it's a, sorry, I have to think, a.fornos@miami.edu.
Okay, just thank you.
Thank you.
Okay, and so you've gotten a lot of people who are very appreciative and enjoyed your presentation very much. And there are no other questions that I'm aware of. If you have a question and I missed it, raise your hand and we can see that. So I don't see any more questions unless, let me see. Nope, I think that's it. So I guess this concludes. Yes. So Emily put in If you're interested in scheduling a consultation with Dr. Fornos, please see the email to the front desk, which is in the chat, and the phone number.